This is Ifra Zawar from the Epilepsy Center at the Neurological Institute at Cleveland Clinic, Ohio, and this presentation is an overview on the chapter named the Electroencephalography in the Outpatient EMU and the ICU setting. Electroencephalogram, or EEG, is the single most essential tool in seizure or event assessment when there is clinical suspicion of epilepsy. It is vital for assessment of electrical brain activity both interictally and during a seizure or ictally. EEG is useful to monitor therapeutic effects of anti-seizure medications and to assess brain maturation in infants. In addition, continuous EEG in the ICU is important for detection of non-convulsive seizures or NCS and non-convulsive status epilepticus or NCSC. Quantitative EEG in the ICU setting provides compressed view of several hours that can also be useful in certain circumstances. In the EMU, intracranial EEG is also extremely helpful for pre-surgical evaluation of patients who suffer from drug-refractory epilepsy. EEG in the outpatient. Routine EEG in the outpatient setting comprises of at least 20 minutes of technically satisfactory recording. Routine EEG may increase test sensitivity if performed within 24 hours of seizure. A single routine EEG has a yield of 30 to 50% in terms of interictal epileptiform discharges. Serial routine EEGs may increase this yield for up to 92% after the fourth EEG. However, in 10 to 19% of epilepsy patients, no epileptiform discharges may be detected despite repeated routine EEGs. Long multi-hour EEG in the outpatient setting can range anywhere from 1 hour to 3 hours. It is conducted in sleep-deprived conditions. It's done when the routine EEG is normal and epileptic seizures are still suspected, or when the seizure control is suboptimal in confirmed epilepsy patients. It increases detection of interictal abnormalities and could be helpful with classification of epilepsy syndromes. Ambulatory EEG is an EEG done when the patient is connected to EEG and sent home, and they are recorded in their living environment and their natural sleep-wake cycles are recorded. It ranges from 24 to 72 hours. It's important for clinical diagnosis and quantification of seizures or events. Epilepsy Monitoring Unit. Epilepsy Monitoring Unit is a gold standard for diagnosis and pre-surgical evaluation of epilepsy patients. Video EEG enables viewing of patients' behavior and seizure semiology during a clinical event which is time-locked to EEG. Indications for admission to Epilepsy Monitoring Unit include clarification of diagnosis and event characterization, clinical assessment of seizures and spells, seizure or syndromic classification, seizure quantification and burden assessment, anti-seizure medication adjustment to differentiate between seizures and side effects, and for pre-surgical evaluation. For clarification of diagnosis, an EMU admission is indicated to see if a typical event is epileptic or non-epileptic in nature, so that we can avoid unnecessary treatment with anti-seizure medications and separate the features and relative proportions of epileptic versus non-epileptic events in patients who have both type of events. It may also be additionally useful to clarify the etiology of non-epileptic events, such as psychogenic events, vasovagal syncope, cardiogenic syncope, movement disorders, sleep-related spells, or migrainous phenomena. Clinical assessment of seizure needs to be done both during the ictal event and post-ictally. Includes a clinical exam, which when combined with video EEG gives us thorough information. Protocol for testing patients during seizures include ensuring bedside safety, establishing responsiveness, testing cognition when possible, and documenting seizure semiology. This figure provides the detail of how patients should be assessed before the seizure, during the seizure, after the seizure, and in between. An EMU admission may be indicated for seizure or syndromic classification to distinguish between different types of seizures and provide diagnosis of the epilepsy syndrome. It is helpful to differentiate focal from generalized epilepsies, and we are able to determine seizure types of syndromes that exhibit differential response with anti-seizure medications. Seizure burden assessment is another reason why patients may require an EMU admission. Seizure burden assessment is crucial for epilepsy management And history may not always be reliable, especially in young children, individuals with intellectual disabilities, or when patients have seizure during sleeps, patients who are amnestic of their seizures, patients with subtle clinical features, or those who have concerns for subclinical seizures. An EMU admission may be indicated for medication adjustment when there is a need to distinguish between medication side effects versus worsening seizures. If the patients experience increased seizure burden despite outpatient anti-seizure medication adjustment, if patients have uncontrolled seizures or recurrent status epilepticus, patients who are at high risk of worsening seizures when anti-seizure medications are switched or discontinued will need an EMU admission to do this. And an EMU admission may be indicated in such cases to evaluate clinical and EEG response to therapy. Monitoring epilepsy patients. Long-term video EEG is recommended after sleep-deprived EEG to potentially reevaluate the diagnosis, to assess therapeutic efficacy of management, and for quantification of EEG abnormality. Pre-surgical evaluation is another indication for EMU admission to reaffirm the diagnosis of focal epilepsy, to document existing seizure types, to confirm the stereotype nature of clinical and EEG features, to systematically review the localizing value of seizure semiology, to regionalize interictal and ictal patterns, and to obtain ictal spec studies if needed. There is no set recommended duration of EMU stay, and the duration depends on indication for admission and time required to record typical events. Patients are assessed daily for anti-seizure medication withdrawal if needed. Seizures are more likely to be recorded if the typical frequency of seizure is greater than or equal to 1 per week, and if they are more likely to occur when anti-seizure medications are reduced. Management plan is guided by results of EMU. How to increase the EEG yield? Various techniques may be implemented to increase the yield of EEG, which include hyperventilation, photic stimulation, sleep deprivation, withdrawal of anti-seizure medications, exercise, and self-reported triggers. Hyperventilation can provoke epileptiform discharges or seizures. It increases diagnostic yield in some epilepsies, especially genetic generalized epilepsies. It is routinely implemented during outpatient EEG and EMU. It is recorded for at least 3 minutes, and at least 1 minute of continued EEG at the end of hyperventilation is also recorded. Photic stimulation is standard practice during routine EEG and EMU to elicit epileptiform discharges or seizures in predisposed patients. It is performed prior to or at least 3 minutes after hyperventilation in a dimly lit room with appropriate stimulation parameters, which include recording for at least 2.5 minutes with eyes open and 2.5 minutes with eyes closed, with a viewing distance of 30 centimeters, using a lamp that delivers flashes at intensity of at least 0.7 joules, and with flash frequencies that typically range between 1 to 30 hertz. Sleep deprivation can be a seizure precipitant in 10 to 30% of epilepsy patients and is a part of seizure-provoking protocols in many EMU. International League Against Epilepsy recommends that adult patients should be sleep deprived the night prior to outpatient EEG, which can be full or partial sleep deprivation. Slow wave sleep deprivation activates focal epileptiform discharges, and REM sleep deprivation can activate both generalized and focal epileptiform discharges. Withdrawing anti-seizure medications to elicit seizures increases yield of an EMU evaluation. Supervised anti-seizure medication tapering in EMU is considered safe as long as it's monitored by trained healthcare professionals and there is adherence to established safety protocols. In such cases, there is less than 1% risk of major complications. However, an EMU team should be able to deal with medical emergencies such as respiratory or cardiac arrest. Withdrawal seizures with benzodiazepine or barbiturate discontinuation may be seen even in patients with no history of epilepsy. Physical activity can trigger seizures and may be considered in the course of EMU admission. However, appropriate safety techniques must always be in place. If spontaneous seizures have not been recorded during an EMU admission, self-reported triggers can sometimes be incorporated during the EMU admission if needed. EEG in epilepsy. Epileptiform discharges are sharply contoured waves that disrupt the EEG background, are followed by an aftercoming slow wave. They are broadly classified as spikes, sharp waves, or polyspikes. They can be focal or generalized depending on the type of epilepsy. They're useful in the diagnosis and classification of epilepsy. They're helpful in identification of certain electroclinical syndromes and in regionalization of the epileptic focus. They are a measure of irritative zone, that is the area of cortical tissue that generates these discharges. Interictal epileptiform discharges increase in frequency near ictal onset, after seizure, during non-REM sleep, following anti-seizure medication withdrawal, and with activation maneuvers such as hyperventilation or photic stimulation. They could be an incidental finding in a minority of patients. However, avoidance of known seizure trigger is still advisable in such patients. Spike. A spike by definition is 40 to 80 milliseconds in duration, as you can see over here. It's a sharply contoured wave that disrupts the EEG background and has an aftercoming slow. This is a longitudinal bipolar montage showing a 9-second epoch with a spike in the right frontotemporal region. Sharp waves are 80 to 200 milliseconds in duration. By definition, they are also sharply contoured. They disrupt the EEG background and have an aftercoming slow that you can see over here. This 10-second epoch in a longitudinal bipolar montage shows two sharp waves in the left temporal region in the 3rd and the 6th second of this patient. Polyspikes by definition have greater than equal to 3 spikes together with a frequency which is typically greater than 10 Hz. These are sharply contoured that disrupt the EEG background and have an aftercoming slow that you can see over here. This is a longitudinal bipolar montage. A 10-second epoch is shown, and the 3rd second you can see this polyspike activity over the left hemisphere, maximum over the temporal region. You can see that the same activity is seen to a lesser degree in the suprasylvian chain over here as well. Ictal pattern. Focal and generalized seizures manifest with distinctly different ictal pattern. Focal EEG seizures are typically characterized by a discernible ictal onset, loss of normal EEG features, evolution of frequency distribution, amplitude, morphology, and/or rhythmicity during the seizure. A discernible end of the EEG change is also seen, which is known as ictal EEG. This slide shows a typical ictal onset. It's a longitudinal bipolar montage. A 15-second epoch is shown. In the 5th second of recording, you can see this low amplitude alpha activity, which is starting in the right temporal region. You can see the evolution of this activity from faster alpha frequencies to slower frequencies as the seizure evolves later on in this page. You can also see the evolution in amplitude. There's a lower amplitude at the start of the seizure, which increases in amplitude towards the later part of the seizure. This slide shows the same seizure 15 seconds later. In addition to involving the right frontotemporal region, this slide shows involvement of the suprasylvian region on the right side as well as the seizure evolves in distribution. This page shows the end of the 61-second long seizure. You can see as the seizure ends, the normal posterior dominant background activity is seen. Some seizures may have subtle or no EEG changes, such as some auras, or focal seizures that only involve a small or deep cortical area. Absence of an EEG ictal pattern during an event does not rule out epilepsy. An ictal pattern is always seen in primary or secondary generalized tonic-clonic seizures, also known as bilateral tonic-clonic seizures. If the seizure spreads quickly to involve both hemispheres, a focal onset may not be apparent on scalp EEG. This phenomena is known as secondary bilateral synchrony. EEG in focal epilepsies. We will be talking about temporal lobe epilepsies, including mesial temporal lobe and neocortical temporal lobe, frontal lobe epilepsies, parietal lobe epilepsies, and occipital lobe epilepsies. EEG in mesial temporal lobe epilepsy. Mesial temporal lobe epilepsy have focal seizures arising from a network involving the mesial structures, including hippocampus, amygdala, and adjacent structures. In these cases, routine EEG may be normal. Sphenoidal electrodes are frequently placed in addition to the regular electrodes between zygoma and mandibular notch to distinguish between mesial and lateral epileptogenic sources. Interictal activity in these epilepsies tend to have anterior temporal spikes, maximum F7, F8, or sphenoidal electrodes in greater than 90% of cases. Epileptiform discharges are seen predominantly ipsilateral to the focus. However, bilateral or contralateral interictal epileptiform discharges may also be seen. Focal slowing in the same region is often. Ictal EEG in mesial temporal lobe epilepsies may have subtle or no EEG change, especially during auras. Clinical onset may precede the EEG onset. Regular lateralized greater than or equal to 5 Hz inferior temporal rhythm within 30 seconds of seizure onset may be present. When this pattern is seen, it's considered relatively specific. It has a good correlation with ictal onset in ipsilateral mesial temporal lobe onsets, and it correctly lateralizes seizure focus in most cases. Lateralization can become problematic in patients with bilateral hippocampal cirrhosis. 70% of seizures show a lateralized postictal slowing ipsilateral to the focus, and this aids in correct lateralization of seizure in the vast majority of patients. This is an EEG example of mesial temporal lobe epilepsy seizure. It's a longitudinal bipolar montage. You can see that in addition to the regular electrodes, this also has sphenoidal electrodes. It's a 15-second epoch, and starting from the 3rd second, you can see some changes in the left temporal region. Moving on to the next 15 seconds of the same seizure, a 5 Hz theta activity is seen within 30 seconds of the onset of the EEG seizure. This rhythm is classically associated with mesial temporal lobe epilepsies. Clinically, this seizure was characterized by oral automatisms and impaired awareness. Neocortical temporal lobe epilepsies have heterogeneous etiologies that can include developmental tumors, focal cortical dysplasia, vascular malformation, trauma, among others. They are less common than mesial temporal lobe epilepsies and usually present later on in life. EEG in the neocortical temporal lobe epilepsies interictally have intermittent rhythmic slow over the temporal region. Ipsilateral interictal epileptiform abnormalities may be seen in 80 to 90% of patients. Ictal EEG tends to have a lateralized polymorphic irregular delta theta activity in the 2 to 5 Hz range. When this activity is seen, it is less likely to be associated with mesial temporal lobe epilepsy and more indicative of neocortical temporal lobe epilepsies. EEG onset tends to be more widespread, lateralized over the ipsilateral hemisphere rather than regionalized over the temporal area. It may be preceded by repetitive spike or followed by rhythmic theta or alpha activity. Bilateral EEG changes are more often seen in neocortical temporal lobe epilepsies compared to mesial temporal lobe epilepsy. This is an EEG showing a classical pattern of neocortical temporal lobe epilepsy seizure. Starting from the 3rd second in this 15-second epoch of a longitudinal bipolar montage, a low amplitude alpha activity is seen, and within a few seconds it evolves into polymorphic delta activity that is seen over the right temporal region towards the end of this patient. EEG in frontal lobe epilepsy. Interictal epileptiform discharges are seen in no more than 65 to 70% of cases, even after repeat EEG. And they tend to have less localizing value compared to interictal epileptiform discharges in temporal lobe epilepsies because of anatomical peculiarities and underlying connectivity of frontal lobe. Interictal epileptiform discharges may be bilateral or midline. Secondary bilateral synchrony is a common phenomena which is seen because of rapid interhemispheric spread. Bilateral spikes or spike wave discharges with amplitude asymmetry may be seen. There can be a brief lag between frontal lobe of origin and the contralateral hemisphere. Ictal EEG in frontal lobe epilepsies. Frontal lobe epilepsies have shorter seizures compared to temporal lobe epilepsies. Ictal EEG may be negative when seizures arise from deep-seated regions or may be obscured by artifact and hyperkinetic or tonic seizures. They can be non-localizable or non-lateralizable, and differences between the two hemispheres may be very subtle, and therefore it may appear generalized. In the setting of secondary bilateral synchrony, it may be falsely lateralizing or obscured by muscle art. This slide shows a frontal lobe seizure onset. It's a longitudinal bipolar montage. A 15-second epoch is shown. You can see that the seizure onset is fairly widespread in the 3rd second of the page. The activity is maximum over the right centrotemporal region, but within a few seconds you can see that the seizure is obscured by a lot of muscle artifact. repetition of the same seizure is seen. Most of the seizure is obscured by muscle artifact, but you can see some evolution in amplitude and frequency over the vertex region in FZ, CZ, and CZ and PZ electrodes. This slide also shows the end of this 22-second brief frontal lobe seizure. Clinically, this seizure was characterized by bilateral asymmetric tonic seizure. EEG in parietal lobe epilepsies. Interictal epileptiform discharges in parietal lobe epilepsies are often non-localizing or falsely localizing. They are variable in distribution within or commonly outside the parietal lobe. They may localize to more than one extraparietal areas within ipsilateral or contralateral hemisphere. Bilateral interictal discharges from interhemispheric propagation are not uncommon. Ictal EEG in parietal lobe epilepsies are also rarely localizable. They falsely localize to ipsilateral temporal or frontal lobe, and correct lateralization or localization can be very challenging, especially in MRI negative parietal lobe epilepsies. EEG in occipital lobe epilepsy is less useful for seizure localization compared to temporal or frontal lobe epilepsies. Less than 20% of patients shows interictal epileptiform discharges that are restricted to the occipital lobe. Localized occipital ictal EEG pattern at onset are seen in only 15 to 20% of the patients. Infracalcarine seizures spread to the ipsilateral temporal lobe, and supracalcarine seizures tend to spread to the ipsilateral parietal and frontal lobes. Generalized epilepsies can be broadly divided into genetic generalized epilepsies, previously termed idiopathic or primary generalized epilepsies, and symptomatic generalized epilepsies. Interictal epileptiform discharges in generalized epilepsies are bisynchronous, symmetric, and generalized, and can include spikes, spike wave complexes, polyspikes, and or polyspike wave complexes. These discharges tend to be more irregular in appearance in the symptomatic compared to genetic generalized epilepsies. Here is an EEG showing generalized polyspikes. A longitudinal bipolar montage is shown. A 15-second epoch is shown. You can see this generalized polyspike activity, which is maximum over the bilateral occipital regions. This EEG shows a typical absence seizure. A bipolar montage is shown. A 12-second epoch is shown. You can see the abrupt EEG onset of seizure characterized by arrest of behavior during this typical absence seizure. On EEG, this is characterized by 3 Hz spike wave activity. Myoclonic seizures and generalized tonic-clonic seizures. Generalized myoclonic seizures have high amplitude generalized polyspikes with frontocentral predominance. They can occur in isolation or can be repetitive, occurring in clusters. Generalized or bilateral tonic-clonic seizures on EEG tend to have a rapid low amplitude spiking, evolving to a slower spike slow wave discharge. This is an EEG example of a myoclonic seizure. A longitudinal bipolar montage with a 15-second epoch is shown. You can see that with the start of vortex stimulation and 15 Hz, myoclonic seizures are shown. 250 milliseconds after the start of vortex stimulation, a generalized polyspike activity is seen. Each high amplitude spike corresponds with a myoclonic jerk. The high amplitude polyspike activity then evolves into spike wave complexes, which reduce in frequency before the end of the seizure. These are associated with predominantly upper extremity jerks. Continuous electroencephalography in the ICU setting. Continuous EEG monitors brain activity. It has reasonable spatial and good temporal resolution. It is sensitive to variation in both brain structure and function. It detects subclinical seizures and newly developing ischemia. It is able to monitor effects of therapeutic intervention and aids in prognostication. What are the indications for continuous EEG? So the details of the indications of continuous EEG are included in the chapter. Briefly, continuous EEG in the ICU setting is indicated to diagnose non-convulsive seizures, or NCS, or non-convulsive status epilepticus, or NCSC, and other seizure-like events. It is used to assess treatment efficacy for seizures and status epilepticus and to identify cerebral ischemia, to assess the effect of sedation and monitor high-dose suppressive treatment, to assess degree of encephalopathy and for prognosis, and to diagnose brain death. Status epilepticus. is the second most frequent neurological emergency, accounting for 10 to 41 cases per 100,000 annually. It is defined as ongoing clinical and/or electrographic seizure lasting longer than or equal to 5 minutes or consecutive recurrent seizures without return of consciousness to neurological baseline. The cutoff of 5 minutes is used because most seizures longer than 5 minutes do not cease spontaneously. Status epilepticus can present with motor symptoms known as convulsive or focal motor status, or without prominent motor symptoms known as non-convulsive status epilepticus. This is a proposed algorithm for the treatment of convulsive status epilepticus. The 0 to 5 minute phase is the stabilization phase, which includes stabilizing the patient in terms of airway breathing circulation, assessing oxygenation, getting an ECG, checking finger blood glucose, getting an IV access, collecting electrolytes, and toxicology screen. If the seizures continue beyond the first 5 minutes, then between 5 to 20 minutes is the initial therapy phase where by administration of intramuscular midazolam or IV lorazepam or diazepam is done. If the seizures still do not terminate beyond 20 minutes, the second therapy phase starts from 20 to 40 minutes, and IV fosphenytoin, valproate, or levetiracetam may be administered. If the seizures continue beyond 40 minutes, then the third therapy phase begins. Continuous EEG during this phase is mandatory, and anesthetic doses of thiopental, midazolam, pentobarbital, or propofol may be used. If at any point during these stages the patient returns to baseline, symptomatic medical treatment is done. For the treatment of refractory status epilepticus, the aim is to attain EEG burst suppression for at least 24 hours, and this is usually established by using anesthetic medications. The management of non-convulsive status seizures can be a matter of debate, and the need for aggressive or less aggressive treatment is generally determined on a case-to-case basis. Detection of non-convulsive seizures, or NCS, and non-convulsive status epilepticus, or NCSC. NCS diagnosis. Subtle clinical signs with NCS or NCSC can involve face and limb myoclonus, nystagmus, eye deviation, pupillary abnormalities, and autonomic instability. These signs are, however, sparse or absent in many cases. Therefore, EEG is indispensable for the diagnosis of NCS and NCSC. Coma is the most common presentation of NCSC, and NCSC was found in 8% of 236 ICU coma patients in one study. Clinical diagnosis of NCS and NCSC can be very difficult in the absence of EEG, as many patients are comatose in the ICU from acute brain injury and/or sedation. Postictal coma and NCS. Subclinical seizures may persist after cessation of clinically apparent convulsive seizures or convulsive status epilepticus. Patients who remain encephalopathic or comatose after convulsive status epilepticus should undergo continuous EEG recordings, as NCS are seen in 33 to 44% of these patients, and NCSC may be present in up to 14% of these patients. Etiology of postictal coma is difficult to establish without EEG, as patients may remain comatose because of ongoing NCS or because of administration of sedative medications. Non-convulsive seizures. Seizures in the neuro-ICU are often non-convulsive and are associated with poor outcomes. In NCS and NCSC, there tends to be decreased level of consciousness and no obvious clinical findings are typically seen. If clinical findings are present, they tend to be subtle and are often minor motor signs. This is an EEG showing brief non-convulsive seizure. It's a longitudinal bipolar montage. A 15-second epoch is seen. The EEG onset of this seizure is seen in the 4th second of this page. The EEG onset is in the right temporal region, maximum over T8 and P8. It is lateralized over the right hemisphere at the time of onset. Later on, the seizure becomes more generalized, involving both hemispheres. The etiologies of non-convulsive seizures can be diverse and include structural lesions, infections, metabolic derangements, toxidromes, autoimmune encephalitis, drug withdrawal, and epilepsy. The criteria for non-convulsive seizures. any pattern lasting at least 10 seconds and satisfying any one of the following three primary criteria can be used. Primary criteria include repetitive generalized or focal spikes, sharp waves, or spike wave complexes at greater than or equal to 3 per second, or repetitive generalized or focal spikes, sharp waves, spike and wave complexes at less than 3 per second, and the secondary criterion. Sequential rhythmic periodic or quasi-periodic waves at greater than or equal to 1 per second and unequivocal evolution in frequency, gradually increasing or decreasing by at least 1 per second, morphology, or location with gradual spread into or out of a region involving at least 2 electrodes can satisfy this criteria. Evolution in amplitude alone, however, is not sufficient. Change in sharpness without other changes in morphology is not enough to satisfy evolution in morphology. Secondary criteria include significant improvement in clinical state or appearance of previously absent normal electroencephalographic patterns, such as posterior dominant alpha rhythm, temporally coupled with acute administration of a rapidly acting anti-epileptic drug. Resolution of epileptiform discharges, leaving diffuse slowing without clinical improvement and without the appearance of previously absent normal electroencephalographic patterns would not satisfy the secondary criteria. Topics of special interest. Traumatic brain injury. The overall seizure incidence within the first week after traumatic brain injury can range anywhere from 2.6 to 16.3%. Purely non-convulsive seizures may be present anywhere in 1/8 to 1/3 of these patients. In one retrospective study of 51 patients, 9 patients had NCS seizures and 4 patients had NCSE. In a study of pediatric ICU, electrographic seizures were seen in 43% of the patients after traumatic brain injury. Post-traumatic brain injury acute symptomatic seizures correlate highly with the severity of traumatic brain injury, are associated with increased ICP. However, it is unclear whether the treatment of these seizures improves clinical outcome or not. Seizure prophylaxis is recommended only for the first week after severe acute traumatic brain injury in adults. Post-traumatic brain injury late seizures occurring after the first week after traumatic brain injury. A single unprovoked late seizure is considered synonymous with epilepsy, and anti-seizure medications are indicated in such cases. Subarachnoid hemorrhage. Convulsive and NCS seizures are frequently seen in aneurysmal subarachnoid hemorrhage with an incidence ranging from 3 to 26%. Occurrence of convulsive seizures at subarachnoid hemorrhage onset has been associated with total subarachnoid hemorrhage blood volume on CT scan. However, whether convulsive seizures in the context of subarachnoid hemorrhage worsen outcome remains controversial. In a study of 108 subarachnoid patients, seizures were detected in 19%, and the vast majority of these seizures were non-convulsive. The need to treat NCS and subarachnoid hemorrhage with anti-seizure medications remains a matter of debate. Factors that are associated with NCS in subarachnoid hemorrhage patients include poor admission Hunt Hess scale, parenchymal bleed, large amount of cisternal bleed, delayed cerebral ischemia, aneurysmal clipping, anterior circulation aneurysm, inflammation following subarachnoid hemorrhage, and lateralized rhythmic delta activity. Factors associated with NCSE in subarachnoid hemorrhage patients include advanced age, coma, brain edema, and hydrocephalus. Clinical seizures at the onset of subarachnoid hemorrhage are associated with poor outcomes. The EEG features that are associated with poor outcomes in subarachnoid hemorrhage include a non-reactive EEG background, absence of sleep architecture, periodic epileptiform discharges, and lateralized periodic discharges. In one study, 90% of those with periodic epileptiform discharges and 95% of those with lateralized periodic discharges on continuous EEG had poor outcomes. Occurrence of NCSE and NCS may be partially responsible for poor outcome in subarachnoid patients, especially when NCS is complicated by pronounced inflammatory responses. Intracranial hemorrhage. The risk for in-hospital convulsive seizures after an ICH ranges from 3 to 19%. Seizure risk increases if there is hematoma expansion, lobar location of ICH, or midline shift. NCS seizures occur anywhere from 18 to 21% of ICH patients. The risk of NCSC within 7 days of hemorrhage is 1 to 6.7%. Periodic epileptiform discharges are seen in 17% of ICH patients. They are more frequent with cortical ICH than deeper hematomas, and they are independently associated with worse outcomes. In cases of ICHs, electrographic seizures should be treated. Anti-seizure medication prophylaxis following ICH is, however, currently not recommended and does not impact the long-term occurrence of seizures. Acute ischemic stroke. Clinically apparent acute seizures are seen anywhere from 1.5 to 9% of acute ischemic stroke patients. Continuous EEG documented acute seizures range anywhere from 6 to 17%. In one study, 11% of 56 patients undergoing continuous EEG had seizures. Purely non-convulsive seizures were present in 83.3% of these patients. Acute clinical seizures are associated with increased mortality in such patients. However, relationship between NCS and stroke outcomes is unknown. Anti-seizure medication prophylaxis in ischemic stroke is currently not recommended. Hypoxic ischemic injury and post-cardiac arrest syndrome. Post-cardiac arrest syndrome. Convulsive and non-convulsive seizures occur anywhere from 10 to 30% of patients with or without therapeutic hypothermia after cardiac arrest. Post-anoxic status epilepticus occurs anywhere from 4 to 28% of these patients. The treatment goal of convulsive seizures or status epilepticus in these patients is cessation of EEG seizures or burst suppression. There is no role of anti-seizure medication prophylaxis in the management of post-cardiac arrest syndrome. Continuous EEG in post-cardiac arrest syndrome is important in seizure detection and prognostication. Therapeutic hypothermia in post-cardiac arrest is often implemented for neuroprotection. This requires sedation and neuromuscular blockade, therefore making the clinical examination unreliable. In this setting, convulsive seizures may be masked, and this makes continuous EEG extremely crucial in these patients. Continuous EEG is recommended in therapeutic hypothermia, during the therapeutic hypothermia, and for 24 hours after rewarming. Post-cardiac arrest syndrome and EEG. EEG might have greater prognostic accuracy under therapeutic hypothermia conditions. EEG factors that are associated with poor outcomes in patients undergoing therapeutic hypothermia include burst suppression, generalized suppression, status epilepticus, and non-reactivity. EEG features that are associated with poor outcomes in post-cardiac arrest syndrome patients who are not undergoing therapeutic hypothermia include background suppression, burst suppression with generalized epileptiform activity, alpha coma, and generalized periodic complexes. Here is an EEG example of background suppression. A longitudinal bipolar montage is shown. A 15-second epoch is shown. You can see the extreme suppressed EEG activity with all of the EEG waves less than 10 microvolts in amplitude. Post-anoxic status epilepticus is an independent predictor of mortality, and aggressive treatment of this may benefit those who have preserved brainstem functions, intact somatosensory evoked potentials, and a reactive EEG background. Infectious encephalopathies. Seizures tend to occur in infectious encephalopathies often, and they are more frequent in viral than bacterial infections. Clinically apparent seizure rates vary anywhere from 6 to 13%, and NCS vary from 10 to 29% in these patients. In one study of 671 patients with bacterial meningitis, seizures were independently associated with mortality. Non-infectious encephalopathies are also often associated with seizures. Toxic metabolic encephalopathy patients, up to 18% of these patients may have NCS seizures, and up to 8% of these patients have shown to have NCSC in various studies. In anti-NMDA receptor encephalitis, EEG pattern of extreme delta brush is specific to NMDA receptor encephalitis, is more prominent with disease progression, and response to immune therapy predating clinical improvement. Overall data on treatment outcomes and prognosis in the context of encephalopathy-related seizure is scarce, and more studies are needed. This is an EEG example of extreme delta brush in a patient with NMDA receptor encephalitis. A longitudinal bipolar montage is shown. You can see the diffuse delta activity throughout all the channels, which is superimposed. Superimposed on this is a faster beta activity, giving it and appearance of extreme delta brush. Ischemia detection. Ischemia may develop in non-ischemic conditions in the ICU, such as subarachnoid hemorrhage, traumatic brain injury, and meningitis. Continuous activity correlates well with cerebral blood flow. Reduction in blood flow is associated with slowing of EEG. So, delayed cerebral ischemia after subarachnoid hemorrhage accounts for a considerable portion of disability and mortality, and it may not always be detected by clinical exam. Detecting this ischemia early on improves outcomes in subarachnoid hemorrhage, and it may be modified by altering systemic blood pressure. So, EEG and ischemia detection. Continuous EEG changes when cerebral blood flow changes. Initially, there is a loss of fast frequencies, there is an increase of slow frequencies, and ultimately, diffuse background attenuation is seen. Quantitative EEG is particularly useful because it makes slow changes easier to track over time. And different EEG algorithms may be employed in different patients for ischemia detection. Most algorithms for ischemia detection in subarachnoid hemorrhage are based on fast Fourier transformation analysis. They include looking at alpha delta ratio, change in total power, composite alpha index, and relative alpha variability. I'm not going to go into the detail of each one of these, but change of alpha delta ratio may be the most suitable parameter in such patients, and composite alpha index can also have a high sensitivity and uh, specificity. Ischemia detection in acute ischemic stroke. Um, so secondary ischemia after acute ischemic stroke can happen, and it depends on the stroke subtype. In minor stroke patients, the risk for recurrent ischemia in the first 7 days after stroke can be as high as 8 to 10%. Therefore, continuous monitoring to detect and prevent ischemia is sometimes done in minor stroke patients and in those patients with symptomatic high-grade carotid stenosis while they are awaiting surgery. Repeat ischemia and acute ischemic stroke. So MRI, as we know, is the gold standard for this, but continuous EEG can also be useful because it drops in cerebral perfusion pressure in ischemic and hemorrhagic strokes are associated with a drop in high frequency power on continuous EEG, and the extent of infarcted brain tissue and long-term outcome after strokes have been correlated with quantitative EEG measures. So this may have some utility in these conditions. However, further studies are needed to evaluate the role of continuous EEG as a part of multimodality ischemia detection. Periodic discharges. It's a common pattern seen after acute brain injury. There's a high incidence of periodic discharges in neuro ICU patients, and these are distinguished according to their localization and presence or absence of bihemispheric synchrony. They're typically classified as generalized periodic discharges, lateralized periodic discharges, bilateral independent periodic discharges, and multifocal discharges. In a study of single or serial spot EEGs, periodic discharges were seen in 10% of the patients. In a series of 102 ICH patients, they were present in 17% of the cases. In a series of 103 subarachnoid patients, they were present in 23% of the cases. Periodic discharges, like seizures, are accompanied by increase in cerebral perfusion and glucose metabolism, can occur in up to 29 to 37% of neuro ICU patients who are on continuous EEG. It is unclear whether patients with periodic discharges should be treated with anti-seizure medications. There is conflicting data about periodic discharges and clinical outcome. In a mixed cohort of neuro ICU, generalized periodic discharges were strongly associated with NCS and NCSC, and NCSC had an independent association with poor functional outcome. However, generalized periodic discharges did not have independent association with poor outcomes. Here is an EEG example of lateralized periodic discharges. A longitudinal bipolar montage is shown. A 10-second epoch is shown. You can see lateralized periodic discharges over the left hemisphere, maximum over the temporal region, occurring at a frequency of 0.8 to 1 Hz. Ictal interictal continuum. Some of the periodic EEG patterns cannot be classified as definitely ictal or interictal. And they fall in the category of ictal interictal continuum. Exactly which one of these EEG phenomena are definitely pathologic and merit appropriate therapeutic intervention remains unclear, and further studies are needed to clarify and address these questions. In conclusion, EEG is an indispensable tool for the assessment of ictal and interictal electrical activity. Outpatient EEG is helpful with for epilepsy diagnosis. EMU admission is helpful for the diagnosis of seizures and other spells, for pre-surgical workup of patients with uncontrolled seizures, and it's also used to monitor therapeutic effects of anti-seizure medications in certain patients. Continuous EEG can provide a global measure of brain function. It increases seizure detection rates, especially in comatose patients. It is used to monitor treatment successes in selected critically ill patients, and it has prognostic significance in certain conditions such as post cardiac arrest syndrome. Thank you.